Thank you, Joe, and I'd like to thank the organisers for giving me time today to talk about this very important, but as was already alluded to, a somewhat neglected area. These are my disclosures. So as Henry told us before, the burden of hepatitis B is very significant, estimated at 250 to 350 million. And if you then put that with the burden of HIV, most recent estimates, but from the WHO, and I would say that these are really just estimates, would put the burden of co-infection at around 2.6 million individuals. And importantly, most of these, as shown by these maps, live in areas of low middle income countries, that is sub-Saharan Africa and Southeast Asia. It's also important to note that this burden of disease is only slightly less than that estimated for hepatitis C co-infection. But hepatitis B co-infection has really been very neglected, particularly of recent, and not a lot of time and attention has been given to it. Now, part of that complacency is because we have had a drug which is highly effective against both HIV and hepatitis B for many years. So tenofovir was licensed in 2001 for the treatment of HIV. As you all know, it's a very potent drug for hepatitis B. And this meta-analysis published last year of 23 studies of co-infected individuals, demonstrating in the 550-odd patients included that the overwhelming majority of patients, whether you're e-antigen negative or positive, whether you're treatment naive or experienced to lamivudine, will suppress over around 5 years of follow-up. And also, very importantly, there's very little evidence of resistance to tenofovir. Now, the success of this drug is reflected, I guess, in all of the guidelines now that recommend, and these are the WHO guidelines from last year, that recommend that tenofovir-containing ART is used first line for all individuals, including those with hepatitis B co-infection. There's also general agreement on the guidelines about when to start. Certainly all guidelines recommend commencement below 500. There is some slight disagreement at a higher level, and you'll note that those things as hepatitis B DNA and fibrosis stage then come into play, and I'll come back to that in a minute. So the question then arises that if the majority of hepatitis B co-infected individuals can be treated with a highly potent drug that has no resistance, what are the challenges remaining in this population? And that's what I'm going to try and cover for the rest of the talk. And certainly there are challenges that remain. And although these are not mutually exclusive, I'm going to sort of divide them into challenges in resource-limited settings and those challenges in resource-rich settings. So firstly, in resource-limited settings or lower middle-income countries, a very major challenge is a very basic one, which is one of diagnosis and monitoring. Now, we really have almost no data on the degree to which hepatitis B co-infected individuals are diagnosed as being co-infected before they start. But this is data from the World Hepatitis Alliance and the WHO Global Survey, looking at testing for viral hepatitis in general in countries. And I think what I want to highlight there is on several important domains, that is accessibility to testing, free testing, anonymous testing. Areas such as Africa and Southeast Asia, where the burden of hepatitis B is really huge, fall well below what we would expect as a standard for diagnostic testing. And in fact, 50% or over 50% of people live in countries with no free testing, and only 4% of low-income countries have ready access to any testing. So there's a first barrier there that many individuals are not diagnosed as being positive before they start their ART. And that means that we do not know who these co-infected individuals are. It means that there is very little understanding even of the natural history of hepatitis B co-infection in these settings. It's also true that liver fibrosis assessment has really not been widely available at all. There is very, very limited access to things like liver biopsy, and there is almost no access to virological monitoring by hepatitis B DNA testing. Now, there is some movement in this area. Certainly rapid tests such as the Determine test for surface antigen and dried blood spot testings, which may allow some point of care without the need for complex infrastructure, some point of care testing of genotype and quantitative or semi-quantitative viral load are certainly being developed and worked on at the moment. Portable FibroScan as well, although again not widely available, at least does offer a potential avenue for assessment of fibrosis in patients. Second challenge in resource-limited settings is one of access. Now, access to tenofovir in low and middle-income countries, although it's obviously supported by the guidelines, is still somewhat limited. Certainly, only 5 years ago, the number of patients who initiated first-line tenofovir-containing ART was as low as 8%. That use is improving. So this is from last year, the global update on HIV treatment, showing that the number of individuals initiating tenofovir as first line is rising up to 30%, whilst that for D4T is obviously falling. The problem is we have no idea whether tenofovir is being preferentially used in the co-infected population because they're simply not diagnosed as being so. There was a small study a couple of years ago which suggested in Tanzania tenofovir-containing ART was used in 3% of HIV mono and 17% of co-infected individuals, suggesting there was some preferential use in co-infection, but it's still way below what would be ideal. And finally, in resource-limited settings, I want to just touch on the issue of mother-to-child transmission because, unlike hepatitis C, hepatitis B is a disease that is usually acquired very early in life through vertical transmission or early horizontal transmission. So if you want to prevent HIV hepatitis B co-infection, you need to prevent infection at the child level. As I said, screening is not routine, and certainly screening of pregnant women for hepatitis B is not routine in many countries. And despite the WHO expanded programme of immunisation, which Henry also mentioned, universal infant vaccination is certainly not universal. This is a slide that Henry showed. And again, I want to draw your attention to the fact that this is looking at third dose coverage, certainly not birth dose, which is even more important. But the green line there at the bottom representing the coverage in Southeast Asia, whereas hepatitis B is highly endemic, showing we're really not getting universal vaccination in some countries still. And even if vaccination is given, the important thing to recognise is that in hepatitis B infected women who have very high viral loads, and those would typically be the HIV co-infected population, the likelihood of perinatal transmission is still around 10%. And so certainly, even in the setting of immunisation, tenofovir-containing ART should really be prioritised to these women, but again, it brings me back to issues of screening and access. What about challenges in resource-rich settings, settings where tenofovir is widely and easily available? We do still see challenges in these settings as well. The first challenge, I guess, is one of suboptimal efficacy, because although I did say that tenofovir was highly potent, no drug is ever 100% effective. And in most of these cohorts that were reported up to 5 years, the number of patients who don't suppress is around 8 to 10%. Now, I think what's unclear is these are 5-year follow-up. What about if you follow people for 10, 20 years? Does that proportion who remain suppressed go up or does it in fact go down? And just a very recent paper from the French in their cohort, a slightly longer follow-up, suggesting that optimal suppression was actually only 78%. So I think we're actually realising that we're not seeing the very, very high rates of optimal suppression that we thought we maybe would. This is an international study that I was involved in from the United States, Australia and Thailand, looking at 165 co-infected individuals followed for about 4 years every 6 months. And in fact, hepatitis B DNA was detectable in around 20% of those patient visits. And there were 3 patterns of detectability. There were patients who never suppressed, who had persistent viremia. There were patients who had viral rebound, and there were patients who had viral blips. And I think one of the challenges is we really don't know why these patterns of viremia on tenofovir occur. We did look at those factors that could be associated with detectable hepatitis B DNA, and in this subgroup analysis where we took just patients who are undetectable by HIV RNA standard, so these are people who are assumed to be adherent to their medication and to certainly to be suppressing hepatitis HIV, that less than 95% adherence is very clearly associated with hepatitis B viremia. So whilst you may be taking enough of your medication to suppress your HIV, certainly you may need even greater adherence to suppress hepatitis B. And I think long-term adherence to medication for patients and clinicians is always a challenge that we need to face. But it's also the case that not everybody who's viremic on tenofovir is non-adherent by any means. And this is one of the real mysteries of hepatitis B, I think, that remain. We don't know why these patients are viremic on tenofovir. They don't have any resistance. Neither phenotypic nor genotypic hepatitis B resistance has been definitively documented. So we really don't know why these patients are remaining viremic. Is it ongoing replication? Is it released from reservoirs? The CCC DNA, which hides in the nuclei of infected hepatocytes, we really don't know. And I think there's quite a lot of work to be done still in this area, both virological work, looking at ultra-deep sequencing, single genome analysis, etc., and some immunological work to look at tenofovir processing to understand why patients remain viremic. What about toxicity? I probably don't need to tell this audience that obviously tenofovir is associated with a small but certainly not insignificant rate of toxicity, both in relation to bone and kidney. And you won't be able to see very clearly, but just one meta-analysis there at the top looking at the effect of tenofovir on kidney, and a very large study of 56,000 patients at the bottom showing a very clear association of tenofovir with bone toxicity. And I think we forget in this era where there are a lot of second-line agents for HIV patients to move to if they get toxicity with tenofovir, that we really are faced with a very different challenge in co-infected patients because it's actually very hard to take them off their tenofovir. There are strategies that we can use. Certainly we can reduce dose tenofovir in some cases. Switching to entecavir is probably the best strategy, but in a patient with prior lamivudine resistance, this is somewhat risky. Adefovir plus entecavir I don't think is a very good strategy with kidney disease, and pegylated interferon really has never really been widely used in the setting of hepatitis B co-infection. So we've really been quite stuck with these patients, and increasingly so. I think there is some room for optimism because we do have, or there is the new Gilead prodrug, tenofovir alafenamide, or TAF, and this is data presented at ICAC last year. This drug is still highly potent against HIV, but has, in this phase 2 studies, less evidence of renal impairment or bone impairment, and certainly this may be an option for hepatitis B co-infected patients, and we really need those studies to tell us whether this could be another option which may be less toxic. What about the final challenge? So I think we're very close. Sanjay's told us we're very close to a cure, or we have cure for hepatitis C. There has been a huge amount of effort and research and money put into a cure for HIV. I think the final challenge for us is really also to look at cure for hepatitis B, because long-term nucleotide therapy for 10, 20, 30, 40 years is not an ideal solution for our patients. There are lots, actually, of avenues that are being now looked at for cure of hepatitis B. I just put up this one paper, which was a recent paper in Science, at a very basic science level still, certainly not in human studies, but just showing that our current strategy for cure, which is loss of surface antigen and seroconversion, really only occurs to any degree with interferon, and it's a very cytopathic and toxic way of achieving cure. This was just one small study looking at a different pathway to degrade that CCC DNA that hides it in nuclei of cells using a lymphotoxin beta receptor agonist, which is non-cytopathic. So I think we need new strategies. We need to keep putting money and research into cure for hepatitis B, just as we have done for the other 2 viral infections. So I leave you with this slide. I hope what I've shown you is that there are challenges at many levels for our patients with HIV and hepatitis B at the policy and advocacy level in terms of epidemiology, and a lot of this I haven't had time to go into, but really understanding the natural history. There are challenges in terms of clinical research, and it's certainly not a game all over area. and in basic science, and looking really for new agents for cure. Thank you.